Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
Thank you all for joining us for today's podcast titled Update on the Management of Restless Legs Syndrome, Part 3. It's been about 2 years since we last did a podcast on restless legs syndrome. And since then, the American Academy of Sleep Medicine has published new clinical guidelines for the management of RLS, and the Scientific and Medical Advisory Board of the Restless Legs Syndrome Foundation has revised their algorithm for restless legs management. In our last 2 podcasts, Dr. Michael Silber, who chaired the task force of the foundation responsible for the recent update, discussed first and second line therapies for the management of RLS. Today, he returns to discuss the management of the patient with dopamine agonist-induced augmentation, as well as some special circumstances, such as management of RLS in the perioperative period. Mike, thank you so much for being here today. It's not infrequent for us to see patients on very high doses of dopamine agonists with devastatingly severe symptoms of RLS. Can you explain for us how situations like this might arise?
Well, thank you, Maitri. Yes, I get a sinking feeling every time I see a patient who is, for instance, on pramipexole 3, 4, 5 milligrams a day. How do these circumstances come about? Well, of course, it has mainly to do with augmentation, which is that increase in severity of restless legs with increasing doses of dopamine agonists that occurs in perhaps at 70% of our patients, maybe a little less, over 8 to 10 years of dopamine agonists. And as we discussed before, that does mean there's at least a 30% of patients who don't seem to develop it, at least over that time course, but the majority will. Now, augmentation, as you may recall, is characterized by restless legs starting early in the day, spreading to the arms and other parts of the body, and then reoccurring during the night, despite what in the past seemed to be adequate doses of dopamine agents. And the essential feature of augmentation is that the higher you push the dose, the worse the augmentation becomes. And this is so counterintuitive and different from almost any other drugs that you use for other conditions that physicians who don't understand this rather unusual phenomenon see that the response to this increasing severity of restless legs should be to increase the dose of the medication, especially as the doses of dopamine agonists we use are usually far lower than those used in Parkinson's disease that most neurologists are more familiar with treating. So when restless legs starts during the day, add extra dopamine agonists. When it breaks through at night, increase the dose before bed. It seems to make logical sense, and it seems counterintuitive to do the opposite, but this is a very special circumstance in which the more you give, the worse the patient is going to get. And that's how we get into these terrible situations when patients are on 3, 4, 5 times or higher the maximum recommended dose of these agents for restless legs.
These patients can obviously be very challenging to manage. Could you tell us, Mike, about the recommended approaches to managing this in the new algorithm? And how successful is this process, really?
Yes. Well, first of all, it goes without saying that the best way to manage augmentation is to prevent it, and that is to stop dopamine agonists as soon as you get the first glimpse of augmentation. And that means following them up carefully, asking the right questions at each visit. Also, keep the doses low. That is the best possible way of reducing, not necessarily eliminating, the risk of augmentation, and thinking very carefully, is a dopamine agonist the right second line treatment rather than something else like an opioid? Okay, so let's say you have somebody in a situation on highish doses of the agonist with horrible augmentation. What do we do? Well, first of all, we reassess systemic iron stores, and if the values allow, which is usually a transferrin saturation of less than 45%, we'll give an intravenous iron infusion. That doesn't cure augmentation, but gives you the best substrate for reducing the medication slowly. Then the second thing we'll do is we'll introduce an agent of a different class. Now, firstly, what does the new algorithm say you shouldn't do? And that is you shouldn't convert short-acting dopamine agonists like pramipexole and ropinirole to longer ones like controlled release pramipexole or the rotigotine patch. In the past, we said this is one way of handling augmentation. We don't think it's a good idea because almost inevitably augmentation will also develop with time on these longer agents. So the first thing we would consider would, of course, be the gabapentinoids. The majority of patients I see with this degree of augmentation have long tried gabapentinoids without success. But if they've never tried it, that would be a first-line drug, even though there is some evidence that gabapentinoids may be less effective in the setting of dopamine augmentation. But we'll use use pregabalin or gabapentin. We push it up to a therapeutic type dose, such as 300 milligrams pregabalin, and only then do we start thinking about reducing the dopamine agonist. But for most of our patients, it's going to be low-dose opioids, and whatever one chooses, oxycodone, methadone, buprenorphine, one pushes the dose up to, again, a therapeutic level, and we discussed a little of this in the past podcasts. Once your alternative agent is at a therapeutic level, we start weaning the dopamine agonist. And we need to consider two things. How high should each step be to reduce a dopamine agonist, and how often should you do it? Well, there's pretty good consensus on the steps. For pramipexole, you should reduce it about 0.25 milligrams a step. For ropinirole, which is 4 times less potent, that would be about 1 milligram a step. And for the rotigotine patch, it's really simple because they only come in 1 milligram steps, so you'll reduce by 1 milligram at a time. What is more controversial or less well understood is how fast should you do it. And really that depends on the patient and the physician. Some patients say, let me get over the pain fast, let's get me off this drug fairly quickly, and others will say, I've had such terrible experiences reducing the dose before, I want to do it very slowly. So the fastest would be every 3 days, taking them down a step, and the slowest would be about once a month. And a whole range between. I tend to go a little slower, but some of my colleagues go much faster, but you've got to do this in partnership with the patient, because every time you reduce a step, with the best will in the world, there's likely to be a flare-up of restless legs, despite that you've covered them with another agent. And you might have to increase the dose of the alternative agent if the flare-up is very bad and hopefully just transient. But that really is a problem, a temporary rebound of restless legs with each reduction in step. When one gets to the very low doses of the agonist, let's say 0.125 milligrams of pramipexole, sometimes the last step after that is impossible. They've done fine up till then, and then you say, right, now we're going to discontinue it altogether, and the whole story flares up. The restless legs becomes uncontrollable. This doesn't happen to everybody, but some patients, you've got to warn them, you may have to stay on a very low dose indefinitely, and that seems to work out fine. Once they're off the dopamine agonist, you can then consider whether to reduce the dose of the alternative agent, especially if you've had to push up the dose as you've done that reduction, reduce the opioid dose, maybe reduce the gabapentinoid dose a bit, not take them off. But if the dose has got rather high, and especially if there's side effects, you may want to try and reduce it. What you don't want to do ever is reintroduce a dopamine agonist again. One shouldn't think about, well, we've got them off, they've given them a so-called drug holiday, now let's try it again, because it's disastrous. Often the second or third time round, there's a shorter latency to augmentation, and it just gets worse and worse. They should just never use dopamine agonists again, the patients you've been able to get off this. How frequently can you get, is this successful, that you get them off most, if not all, of the dopamine agonist? The best study suggests about 70% of patients we can get off to a baseline, but there remain a really difficult 30% of patients who we can reduce the dose. We add other agents, but it's very, very hard to get them off altogether. It's just such an agonizing process for that group. And it's really difficult, which of course is one of the reasons why we are expressing considerable caution with the dopamine agonists. Not never use them, but think carefully of alternative second-line agents like the low-dose opioids, the use of perineal nerve stimulation, maybe dipyridamole. Think of other agents, but if in discussion with your patient by joint decision-making you decide a dopamine agonist should be tried, low dose, and monitor them carefully and be prepared to stop before these terrible effects happen, and never, never increase the dose of a dopamine agonist when augmentation is starting. And basically, if there's any worsening of restless legs on a dopamine agonist, consider that to be augmentation until otherwise proven.
A very challenging patient population to manage. Indeed. Thank you for sharing that, Mike. So let's now change direction and discuss the patient who is about to undergo surgery and is desperately worried about an exacerbation of restless legs symptoms. What advice can we give under this circumstance?
Yes, this is very scary to patients, especially if they have to be in hospital, immobilized, and especially if they've had a past bad experience with prior surgery. So first of all, be sure that the physicians, surgeons looking after the patient in hospital are aware of the condition, and that if at all possible, the patient's baseline restless legs medications will be continued during the hospital stay, if at all possible. After the surgery, there's certain things which are so common after surgery you want to try avoid. The first of these is avoid sleep deprivation. That may not be so easy in a busy hospital unit, an intensive care unit, patient with pain, being monitored with blood pressures all hours of the night, but try and avoid sleep deprivation as much as possible. Then keep immobilization to a minimum. Now, that's not always possible after some orthopedic surgeries. They really have to be immobilized for a while, but keep it to an absolute minimum and mobilize the patient. Encourage early ambulation as much as is feasible. Then the next situation that sometimes arises is that in the immediate hours after surgery, especially, and sometimes days, terrible restless legs develops, and the patient, a sort of twilight state, may appear to be confused, writhing around in bed in agony from the restless legs. And the response to protect the surgical site is sometimes even to use restraints, which would be utterly intolerable to a restless legs patient, or to sedate them. And the sort of drugs that are used are often neuroleptic agents like haloperidol, which of course are dopamine blockers and will just further exacerbate it. So in a patient in this sort of state, differentiate the severe restless legs from true postoperative delirium. Then avoid medications that can exacerbate restless legs. We've talked about the dopamine antagonist neuroleptic agents, but far commoner would be anti-nausea agents, often anesthetic and surgery, metoclopramide, and other similar drugs are anti-dopaminergic. Some of them have antihistamine effects, all very bad for restless legs. If one has to control nausea, use ondansetron or similar serotonin-based antiemetic agents. Now, most surgeries don't involve a lot of blood loss, but some do, major surgeries. Generally, surgeons would say, well, the hemoglobin's 8.5 or 9. With time, we'll give some oral iron. With time, it will all replenish itself. But if restless legs worsens in these sort of situations, you may have to think differently about an iron infusion or maybe even a blood transfusion if the hemoglobin's dropped too far and restless legs is happening. Going back to medications, there are situations in which the patient can not take oral agents after surgery, especially gastrointestinal surgeries. If they're on a dopamine agonist, there's often a simple solution, and that's to convert oral ropinirole or pramipexole to the rotigotine patch. And that sometimes solves the problem very easily. For gabapentinoids and opioids, it may not be quite as easy. So let's next talk about a patient who is on low-dose opioids before surgery. This often worries surgeons and anesthesiologists. There's a lot of experience, however, on this on patients who are using opioids for chronic pain. Less studies on restless legs patients, but we can extrapolate. If a patient is on buprenorphine or methadone, it is perfectly safe to continue the same dose postoperatively and supplement with oxycodone or other conventional opioids. That's the way to do it. It is safe to do that. For patients who are on chronic oxycodone, hydrocodone, or morphine, you may have to increase the dose because there's been some tolerance to pain perhaps developed over years of use, so the dose may have to be increased. For patients who are not on chronic opioid therapy, one wants to use as little postoperative opioids as compatible with adequate pain relief and get them off as quickly as possible, because we do have the phenomenon of restless legs rebound after opioid withdrawal. So you want to use as little as possible for as short a time as possible. Now, there are some patients that won't work and they've got to be on higher dose opioids for a longer time postoperatively. If they reach higher levels, then you want to wean them slowly again to try and avoid the rebound of restless legs. So these are some of the hints which we can bear in mind. And I tend, when a patient tells me I'm going in for surgery, I'm so scared, I write a whole note in the chart about all these things and tell the patient to tell the admitting physician to read my last note about it, because as we all know, a surgeon or a surgical resident admitting someone to hospital may not go through all these medical and neurologic notes in any great detail. I think the bottom line is the patient has to take control of the disease themselves in working with their surgical team.
And how about another special circumstance, that of management of RLS and end-stage renal failure, Mike, where it commonly occurs? Many of the medications that we use to treat restless legs syndrome are excreted by the kidneys. So, how should one approach management of RLS symptoms in this group of patients?
Well, this, of course, is a much more specialized area, but it's certainly, we see patients referred by their nephrologists, and I think we do have to discuss this because restless legs is very common in end-stage renal disease and dialysis patients. Well, first of all, the frequency has dropped since erythropoietin has been used fairly regularly in these patients. So one just wants to always assess the iron status and replenish iron if the iron stores are low. There have been quite a few studies of non-pharmacologic management of restless legs during dialysis and in end-stage renal failure. Massage and exercise may be helpful. And interestingly, there's one controlled study, I think it's almost the only one of vitamins in restless legs that's been positive, suggesting perhaps vitamin C and vitamin E in end-stage renal failure might be helpful. There's also a study suggesting that perhaps if you dialyze them with dialysate 1 or 1.5 degrees Celsius cooler than usual, it might be helpful. I have no experience with this. I discussed it with one of our nephrologists and they didn't have any experience or couldn't really comment on that. So let's go to the medications. As you correctly say, Maitri, the most commonly used first-line agents today, the gabapentinoids, are excreted by the kidneys. That doesn't mean you can't use them, but you've got to reduce the dose. You've got to monitor for side effects, especially drowsiness and unsteadiness. And sometimes it's best to give perhaps on a dialysis day or the following evening when they are undergoing dialysis or post-dialysis. If the dopamine agonists are being used, it's important to realize that pramipexole is excreted by the kidneys, whereas ropinirole and rotigotine are metabolized by the liver to inactive metabolites excreted by the kidneys. So for end-stage renal disease, dopamine agonists use ropinirole or rotigotine and not pramipexole. Which gets us to the opioids. Some of these patients will already be on low-dose opioids, or others will have such severe restless legs that we really need to put them onto low-dose opioids. So we have to understand how opioids are metabolized. Morphine and oxycodone are metabolized in the liver to active products, metabolites, which are excreted by the kidneys. So morphine is especially dangerous in end-stage renal disease. 90% of the drug and its metabolites are renal excreted. Oxycodone, at least 50%. So never use morphine. Oxycodone, be very careful with. On the other hand, methadone is metabolized in the liver to inactive metabolites excreted by the kidneys, so it is relatively safe in end-stage renal disease. And buprenorphine is metabolized by the liver to active metabolites, but they're not excreted by the kidneys. They're excreted in the feces, which is so interesting. So the opioids of choice for end-stage renal disease would be low-dose methadone or low-dose buprenorphine. The final point I'd make is that it is almost miraculous to see how most patients with intense restless legs, their symptoms almost entirely resolve after kidney transplantation. So there is light at the end of the tunnel for those patients on dialysis who are in line for a kidney transplant. Often the restless legs melts away.
Mike, thank you so much for sharing your expertise on the management of restless legs in these last 3 podcasts. Do you have any final messages that you would like to leave with our listeners today?
Well, thank you, my3. We've covered a lot of ground. I'd simply say always think of iron in patients with chronic persistent restless legs. Relax over the ferritin levels if they're less than 300. If the percentage saturation is less than 45%, think about iron infusions with the correct form of iron. Gabapentinoids are first-line agents, though they do have side effects and are not always effective. For second-line agents, think about the low-dose opioids, relatively safe if you understand them and the side effects, but of course with regulatory requirements and stigmas, difficulty sometimes with prescription. Dopamine agonists are never first-line agents, but they can be considered as second-line agents by joint decision-making if the risks of augmentation and impulse control disorders are considered. Doses are kept low and the patient's carefully monitored and the drug stopped if the side effects develop. A nice new intervention, maybe the perineal nerve stimulator as adjunctive therapy especially, and dipyridamole is a possibility, though we're not convinced that it's an utterly fantastic agent. For special circumstances, one has to be aware of all the issues I discussed today, and physicians managing patients who are already augmented have to be familiar with a protocol of how best to do it. Restless legs is common. It can be very severe. We are not at the end of the road yet with management. We need better therapies in the future, but we're making progress, and we hope that the new approaches we're outlining here will be helpful to physicians and to their patients.
Thank you so much, Mike, and thank you to our listeners for joining us today.
We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.